Okay, good afternoon. So I'm going to try not to have too much overlap with anything that Mark covered. This is generally what my learning objectives are, going through definitions and epidemiology and impact, and then talking about preventability, and then going into the meat of the lecture, which is really coordinated team responses. Excuse me, can I have the timer? Thank you. But Mark already went through all the definitions, and so I'm not really going to spend any more time on that. And he already hopefully convinced you, talked about the incidence and the prevalence of hemorrhage and its role in maternal morbidity and mortality. And so again, I'm not really going to spend any more time on that. So that's the fastest I've ever gotten through those topics. Thanks, Mark. And now we can just go straight to this idea of preventability, okay? And so this is an example. These data were based on review of maternal deaths in the state of North Carolina. There were 108 deaths looked at, and maternal death was defined as during or within 1 year of pregnancy and somehow related to the pregnancy. These deaths were looked at for cause of death and preventability using a previously validated panel-based technique. And then they further assigned preventability to issues with either preconception care or patient systems or provider-related factors. And what they found was that there were a large percentage of deaths that were considered preventable. Overall, 40% of deaths were preventable, and 54% of those deaths were due to provider-related factors, most of them having to do with delays in either diagnosis or treatment. A whopping 93% of the deaths due to hemorrhage were considered preventable. This is similar data, comes out of France, where throughout the country they have a protocolized way of dealing with hemorrhage. So a lot of the data on hemorrhage comes from French studies within the past 10 years or so. But this group looked at severe versus non-severe hemorrhage, and severe was based on the degree of blood loss, but also on like development of coagulopathy and need for higher level procedures, et cetera. So it was a pretty good definition of severe. And then they assessed what factors were associated with severe versus non-severe hemorrhage. And delaying oxytocin administration by as little as 10 minutes was associated with an increased risk for severe hemorrhage. Delaying manual exploration of the uterus for 20 minutes. Failing to call for assistance in a timely manner was associated with an increased risk of severity. And lastly, I have to throw this in, the provision of epidural analgesia was actually associated with a lower risk of severe hemorrhage, and it was thought that perhaps the presence of epidural analgesia allowed for the obstetrician to do a quicker manual exam, and it also was more likely than an anesthesiologist would be involved in the patient's care. So of course that's one of my favorite pieces of data in all time. This also came out of France. Again, this group looked at severe versus non-severe hemorrhage, and again, severe hemorrhage was often accompanied by what they called substandard care, but the substandard care usually involved delays in either diagnosis and treatment. And then here's my second piece of data in all time, because it validates all our existence, but the substandard care was associated with a lack of what they called an anesthetist on the unit. So why are we all so bad at this? We know that hemorrhage is bad, we know that it can kill patients. And I think Mark went through some of these, so again, I'm not going to spend a lot of time on this, but the first factor has to do with how bad we are at estimating blood loss. And that's why you'll see, and when we get into protocols, that they're going to call more and more for quantification of blood loss, use of calibrated drapes and weighing, as Mark suggested. The second factor has to do with how late changes in vital signs occur in young, healthy patients. This comes from the trauma literature. Admittedly, it's never been validated in pregnancy. However, it's thought that it's probably similar, and if anything, because pregnant women have, Mother Nature has provided pregnant women with a lot of factors like increases in their circulating plasma volume, et cetera, that help them deal with blood loss. If anything, it's thought that pregnant women can probably hide blood loss even more so than other young, healthy patients. But anyway, this is from the trauma literature, and what you'll see is basically that a patient may not develop worrisome changes in heart rate or blood pressure until they've lost, a large percentage of their blood volume, sometimes up to like 30 or 40%. The third factor that may lead to these delays in effective treatment has to do with the rapidity with which obstetrically hemorrhaging patients develop a coagulopathy. The placental bed is full of all kinds of procoagulants, and it's thought, and there's some evidence to support this too, that when the placenta separates, some of those procoagulants are excreted into the central circulation. And this probably serves an important function, important procoagulant function after delivery. However, it's thought that perhaps with continued bleeding from the placental bed, that release of these factors can actually feed a consumptive coagulopathy. And that obstetric hemorrhage, as compared to traumatic hemorrhage or other types of hemorrhage, is actually associated with a consumptive coagulopathy that's out of proportion to just dilution by crystalloid and colloid and red cell transfusion. So far, you can consider this kind of the bad news. Hemorrhage is high, it's increasing in this country, it contributes to morbidity and mortality, and a lot of that morbidity and mortality is preventable if we could only diagnose and effectively treat it. Okay, so that's all the bad news. But now we're going to get into the good news, because it turns out that provider-related factors are often amenable to protocol-driven care. And so Mark briefly mentioned these SHIELD studies, but I kind of want to go into them in a little bit more detail, because I think they provide the best data we have so far that these hemorrhage programs and protocols actually improve outcomes. So Dr. Shields and his team, they work out in California, where, as you just learned, the QMCCC mandates hemorrhage programs at their birthing facilities. The first study is the older one, the one on top there, and they looked at outcomes just in their own hospital, pre and post protocol, so it involved about 5,000 patients. The newer study, which is the one lower down, they looked throughout their whole system, so it involved about 32,000 patients. Again, looked at pre and then post protocol in 2 different periods. And again, this whole program involved risk assessments, quantification of blood loss, and protocols to get people to the room. I just want to quickly show you what their protocol looked at. This was their risk assessment tool, and you can just see that for various factors, it determined how they were going to prepare for blood products. They called this stage 0. In other words, this is all patients who deliver, no matter how low risk they seem. And what you'll notice on this is that if there's any evidence at all of hypoperfusion, so any evidence of a decrease in vital signs, et cetera, again, these early warning systems, even if you think the blood loss is okay, you go straight to a higher stage. In other words, no matter how quantified you try and be about your blood loss, you have to understand that you're not good at it. This is their stage 1, so this is when they suspect that there might be abnormal bleeding. And there is a little bit of medicine out here to the side. It tells you your doses in case you forgot of your urotonics rather. But these protocols aren't meant to teach any of us medicine. It's assumed that all the doctors and nurses taking care of these patients already know the medicine. The protocols really focus on team responses. So you'll notice that if the team suspects abnormal blood loss, that all of this has to do with calling for more people to come into the room, weighing and getting more quantified about your blood loss, and also increasing the frequency of assessing vital signs, because we know, again, from the trauma literature, that patients will do fine and then all of a sudden fall off of a cliff. This is their stage 2. The primary goal is just getting additional personnel to the room, so calling your anesthesia providers, calling additional obstetric providers, etc. And then for stage 3, which again is defined as based on the EBL, but also if there's any suspicion of coagulopathy, by the time a coagulopathy is developed, you are way, way behind. And so the whole point to this part of the protocol, the stage 3 protocol, is trying to limit additional blood loss and limit development of coagulopathy and DIC. So you'll see that you're supposed to be getting labs every half hour, and that you have to call your blood bank and get additional people in the room. You're talking about reassigning staff, calling your gynae oncologists, etc. And so does this stuff really work? These are the data from the first study, the older one. It's a little bit hard to understand just looking at it, but basically this is the percentage of patients successfully treated at that particular stage. I guess you can't see my mouse up there. Pre and post protocol. So in other words, before the protocol, 33% of patients who presented in stage 1 were successfully treated at that stage, meaning 67% got worse. Post-protocol, 82% of patients who presented at stage 1 were successfully treated at that stage. Similarly, pre-protocol, only 8% of patients who got to stage 2 stayed there. Everyone else advanced, whereas post-protocol, 50% of patients were successfully treated at stage 2. And then even though there was this emphasis on keeping on top of labs and diagnosing the coagulopathy and treating the coagulopathy, overall there was a decrease in the transfusion rate. These are the data that came from the larger study. Again, there was a decrease in transfusions per 1,000 births pre and post protocol. Interestingly, there was also this decrease in hysterectomy. You'll notice the p-value is 0.2, so it was non-significant, and that may still just be a power issue. Even with 32,000 deliveries, it's probably not enough power to pick up an outcome like hysterectomy. But it's certainly a provocative finding. So just to summarize, the use of a hemorrhage program that involves risk assessment and protocols and drills can decrease severity of hemorrhage, decrease development of DIC, decrease transfusions. It may be associated with a decrease in the rate of hysterectomy for hemorrhage. And importantly, it will increase staff knowledge and confidence in handling these situations. Because of the success of this program in California, Elliot Main, who was kind of the brains behind the CMQCC, approached ACOG about developing this nationally. And ACOG formed the National Partnership for Maternal Safety, which eventually found a home in ACOG's Council on Patient Safety for Women's Healthcare, which is a mouthful. But it includes all major stakeholders in women's health, so ACOG, the Society for Maternal Fetal Medicine, the ASA, SOAP, the AANA, AWAN, the American Hospital Association, and their mission is to improve safety and reduce harm by fostering multidisciplinary collaboration, which will drive culture change. You can find their website at safehealthcareforeverywoman.org. You will find the main work product of this group, which is their patient safety bundles. When you click on that, you'll find maternal safety bundles, and here's the one on hemorrhage. So when you click on that, the first thing you're going to see is this page, and there's a downloadable PDF of the bundle, which looks something like this. It's organized according to the 4 R's, as Mark said, so readiness, recognition and prevention, response, and then reporting and systems. The next thing you'll see is the supporting commentary and a several-page document that goes into each of these 4 R's in detail was co-published in the anesthesia literature, the midwifery journal, the OB literature, and OB nursing journal. And this was actually quite a feat because journals don't generally like to share their work product because it's all about citations. And in other words, if something gets published in ANA, an anesthesiologist may cite the ANA version of it, and then the Green Journal loses out on that impact factor. So the fact that we were actually able to accomplish the co-publication in 4 journals is an indication of just how important this work is felt to be. And of course, since I'm an anesthesiologist, indeed, I do cite the ANA version. It was published, here's the citation for it. It'll be in your slides. It was accompanied by this editorial also. Anyway, to get to the bundle itself, so under readiness, these are the elements of readiness. It calls for a cart with supplies. You should have one on labor and delivery as well as on your postpartum unit, especially if your postpartum unit is several floors away. Medications, it can be hard to store on a cart because you've got to keep it locked. Some medications have to be refrigerated. You're going to have to work with your pharmacy to see how you can very quickly get medications when you need them. You need to form a team, and you also have to figure out a quick way to call everybody. You need to work with your blood bank so that you can get plasma and cryoprecipitate, et cetera, quickly when you need it. And low resource centers, some birthing centers and some hospitals in rural areas may not have blood banks or may not have blood banks with a large supply. You need to work out a system for how you're going to either transfer your patients out or get your blood in when unexpected hemorrhage occurs. And then I think this is probably one of the hardest things is having a system for doing drills. And I think in part the reason that gets so hard is because people try and be too fancy about it. I think you should just aim for low fidelity. Just call everyone to the room and just pretend someone's in there hemorrhaging and then just tell everybody to do what they need to do. At the bottom of each of these elements, you'll see this readiness resources. If you click on that, if you don't know what to put on a cart, you can look at what other people have done. If you don't know how to what medications you need available, you can look and see what other people have done. So I think these readiness resources are things you're really going to want to use. The next R is recognition and prevention. So the first one was every unit. So recognition and prevention is what you do for every patient. So you have to assess risk, not just prenatally and on admission, but several times throughout labor. For instance, when someone enters active phase labor, that might be a time that you assess risk again. Has the patient developed chorioamnionitis? Is she now a higher risk patient than she was when she was admitted several hours ago? Again, we've talked a lot about cumulative blood loss and quantitative blood loss, weighing and using calibrated drapes, and then having a active management of third stage of labor. And again, if you, for instance, don't have an assessment, a risk assessment tool, or you don't have a protocol for active management, just go to the resources and you can find what other people have done, and that will help you implement this on your unit. So how do you respond? This is something that should happen for every hemorrhage. A unit-based, stage-based protocol. And so what we mean by stage-based is not just, it's going to be partly based on the volume of blood loss. But again, since we know we're bad at that, it's also got to be based on vital sign triggers and on any suspicion of coagulopathy. And then a support program should include debriefing after an event. And again, if you, I found this very intimidating even when I had to write the protocol for our unit. It's just a lot to do, and so there are a lot of resources out there. There's no need for you to reinvent the wheel. You're going to have to modify some of these protocols to fit your unit in your hospital, but people have done a lot of work ahead of you. The last R has to do with reporting and systems learning, and again, this is something that should apply to every unit. You need to develop a culture of briefs, huddles, and debriefs. A brief is referred to as a planning meeting, so how you're going to handle a certain patient. A huddle is something that occurs ad hoc. If all of a sudden something changes, if all of a sudden the risk changes, if all of a sudden you're going to the operating room, a quick ad hoc multidisciplinary meeting to make a plan, and then debriefs occur after events. Reviews are different from debriefs. They're more formal. These should be sanctioned by your facility. They should be free from discovery, and they should focus on systems issues and doing a root cause analysis. And again, there are resources available that will help you learn how to develop these types of review systems. When you monitor, it's recommended that you first monitor process metrics. So you can go through charts and measure how often you followed the protocol, how often you were able to deliver medications within 10 minutes, that sort of thing. An outcome metric is how did the patient do. It's recommended that you measure how often patients need transfusions of 4 or more units of blood, or how often patients need admission to an ICU for hemorrhage. Again, there are resources available. All of this in detail is in that bundle that's published in Anesthesia and Analgesia. Okay, if you want all the details, everything that I've just said, it's all in that published bundle. There are a few other resources that the National Partnership for Maternal Safety provides on its website. So you'll see these patient safety tools. The maternal early warning criteria can be found there. So this was published by Jill Meyer. She led this work group, but it was part of the National Partnership for Maternal Safety. These are the early warning criteria. There's nothing crazy here. You can even just embed these into your electronic health record. You can also find severe maternal morbidity forms. These are meant to aid you in your reviews. It was published in Obstetrics and Gynecology. Again, this was actually the result of a work group from the National Partnership, but it includes information and how, what sort of triggers you should look for, how you might do a chart extraction. It's very helpful because this is, I think, also, putting the protocol into place was probably, as hard as that was a little easier than implementing this review process. And I think that's what we're finding as we talk to people all over the country at the partnership. But there is help out there. The last is the toolkits. You'll find this Implementing Quality Improvement Projects Toolkits. It is just it's like 60-page resource of different toolkits available for protocols, risk assessment tools, morbidity reviews, etc. It's really helpful. So as intimidating as it can sound to put these programs into place, there really is a lot out there. The Council on Patient Safety also produces a safety action series. You can sign up for it. They'll send you flyers every month, and then you'll know when those safety action series are being broadcast by a webinar, and you can even set it up and your whole group can watch together. The council, has these quality improvement competitions. It's all meant as a friendly competition. There was one on hemorrhage. There's going to be one on thromboprophylaxis. Your group can, if you institute one of these quality improvement programs and then you measure either process or outcome metrics, you can submit that. There's a small monetary prize, but of course we're mostly in it for the glory. This is a slide that shows all the different groups that are part of this national partnership. So again, several anesthesia groups, several obstetric and maternal fetal medicine groups, nursing groups, midwifery groups. The American Hospital Association endorses this. The Joint Commission endorses this, and not only endorses this, the Joint Commission is going to make adoption of these patient safety bundles mandatory. And so if the data doesn't convince you, the Joint Commission is going to convince you. You are going to have to do this, okay? So just remember the website, safehealthcareforeverywoman.org. And even third-party payers are catching on to this. I know in my home state of Illinois, just this week, I got an email from our executive director stating that Blue Cross Blue Shield wanted to know which of the patient safety bundles we had implemented in its entirety. Because unless we have implemented at least one patient safety bundle in its entirety, then they're not going to contract with us. And so this is being supported by these groups, and we're all going to have to be doing it. There's my email. If you have any questions, you need any help, please don't hesitate to email me about this. Thank you for your attention.